Again, advancing accountable care with new payment models. I'm going to ask each of our panels to introduce himself, starting with Michael far left. And Michael, as you introduce yourself, kind of, not just your name and affiliation, but what it is about your job that attaches itself to our issue of accountable care. Michael?
Okay. All right. I am Mike Funk. I am currently the Vice President in our Office of the Chief Medical Officer. Prior to that, though, I have 37 years, all with Humana. But for those of you who may or may not be familiar with Humana, we started out as actually a nursing home company. I'm not that old. But we then integrated into one of the largest for-profit hospital companies, and then vertically integrated through primary care, staff models into an insurance business, and then we spun our hospitals off. So I have a long career in a number of different settings, both on delivering care as well as managed care. I've been in the Office of the Chief Medical Officer for the last probably year, and my focus has really been twofold there. It's been continuing the work that I was doing previously in our Provider Development Center of Excellence, where we were focused on the transformation and helping providers with best practices, tools, and capabilities to make the transition from fee-for-service to value-based care. So I've continued a lot of those responsibilities in addition to beginning to move our organization from what has historically been a very business approach to bringing more clinical, infusing the clinical expertise and voice of the provider into our organization, both from the number of providers we employ within our organization, physicians, nurses, social workers, pharmacists, to those individuals that we actually contract with in a network relationship.
Okay. Great, thanks very much, Mike. And Tim?
Yeah, good morning. My name is Tim Gronniger with Caravan Health. I have spent about the last 10 years working on payment reform in different capacities, mostly in regards to Medicare and Medicaid. I spent a number of years on Capitol Hill and then at the Center for Medicare and Medicaid Services, working on creating the Medicare Shared Savings Program, the Center for Medicare and Medicaid Innovation, and now at Caravan Health, we, for those of you who don't know us, we help hospitals and physicians work together to create and manage accountable care organizations, generally, as well as a few other value-based purchasing programs. But our interest and our desire is to help hospitals and physicians work together to deliver better primary care, but more coordinated care, using data, using tools. And so our interest is in seeing payment that will support that better delivery of care.
When did you leave government?
January of 2017.
It was recent, because you and I met when you were working for the feds. I remember that. Thanks, Tim. By the way, I think you and I share the same congressman, now that I'm looking at our geographies here.
Well, I'm on the Maryland side, so.
Yeah,
are you?
I live,
okay.
You and I have the same congressman in Maryland.
Okay.
Side issue. John, you are not in Knoxville, Tennessee. You're with Cherokee, so the slide's wrong, but correct it for us, please.
Yeah, I'm John McConnell from Oregon Health and Science University in Portland, Oregon. I'm a health economist. I think I'm here primarily to describe what Oregon has done with its Medicaid program. In 2012, they moved into a system they call coordinated care organizations. So these are 16 CCOs that have some similarities to kind of Medicare ACOs and some similarities to Medicaid managed care organizations. And so we've been observing that transition, studying it, and looking at their shift into what they call CCO 2.0, which is where they're going in the next 5 years.
Good, thanks very much. I look forward to hearing about that. David.
So David Muhlestein, I'm the Chief Research Officer with Leavitt Partners. And Leavitt Partners is a healthcare consulting firm started by Mike Leavitt, who was the previous HHS Secretary. The goal is to help people understand how the healthcare system is evolving.
He's a few HHS secretaries ago.
Yeah,
A
previous, yeah. My job over the last about 7 years has been to study accountable care organizations, to understand how payment reform is driving delivery reform and figure out the implications of that. So we do a lot of quantitative work with tracking and monitoring what's going on, and then a lot of qualitative work. Thousands of surveys and interviews and different touch points with these organizations to find out what's working and what's not working. I also work with a nonprofit Accountable Care Learning Collaborative, which is a coalition of providers and other healthcare stakeholders that have the objective of identifying the competencies and skill sets necessary to successfully manage a population, and then try to take the best learnings from that group and then disseminate them. We found through trial and error that most people are just reinventing the wheel for themselves. Rather than taking what's been learned and reapplying it in their own organization, they say, we can do it better, let's just start from scratch. And that's not the most efficient way of moving toward this accountable care. I also spent a lot of time more recently working on the business case of accountable care. These are voluntary programs, and most people still live under a fee-for-service mentality, and it's a fee-for-service system that pays the bills. So how do you create a business case to make that transition, which is a challenge?
So what you have, one reason I'm really excited about this panel is that you have people that are not only trying to make these things happen, you've got people that are studying them and trying to kind of feed back lessons. And already David's made one of the most important observations you're going to hear today, which is we're not learning as we go very well and sharing best practices. There are a lot of one-offs out there, and there's a great upside for what we could learn from each other, but we haven't taken advantage of that yet. So thank you very much for that. Mike, just back to you, and I know it's going to be hard to be brief about this, but tell us what you are, through Humana, what you're doing with accountable care and how you're advancing it. So give it that to us in a nutshell. What are you up to?
Yeah, so let me just really quick bring you up to speed. You know, we started out very primary care centric in our approach to integrated care delivery. And we've been at this probably for 7 or 8 years now. What I'm going to talk to mainly is on the MA side, because that's where we have the deepest and richest experience, but we do have commercial membership as well, but we are a large Medicare provider. So we started with primary care. We have evolved recently to bundled payments, oncology programs, OBGYN programs. We just started a commercial hospital inpatient program. So we're beginning to evolve in the specialty space, but a lot of it has been around the primary care physician. To date, we have over 1,000 accountable care relationships with anywhere from individual practicing physicians all the way up to highly sophisticated integrated delivery systems.
So you're managing a portfolio of 1,000 accountable care relationships.
Correct. And all across the board. You've seen one. We have 66% of our Medicare Advantage population in accountable care programs today, which is nearly 2 million individual lives. And we'll talk about the success of what we're seeing on those here in just a bit. But that is an overview. And again, I think what's important is our strategy has been meeting the provider where they are. There's a lot of emphasis on risk. And I'm here to say not everybody is ready for risk, and we're not going to push anybody there before their time. And there may be some provider organizations, and probably will be, that will never make it to the transition of risk. But that path to value space can be just as impactful.
Point well taken. Thank you very much. Tim, what do you got with Caravan and accountable care?
It's a good segue and good introduction for the way we approach the work. And just a side note on the point you made about risk, it's the way everyone in Washington knows things that are going to happen before they happen. CMS looks absolutely determined to close down the non-risk bearing track of the Medicare Shared Savings Program, which I think is really important potential development that we should probably talk about. But first, to answer your direct question, we take a different approach. We try to recognize that not everyone should have their own, should start from scratch and should start from a position of let's have every hospital physician collaboration in the country relearn what the ACO program is all about. So we provide the structure that allows our clients to join the program successfully. We come in with a very specific clinical approach for a baseline set of objectives in the accountable care program, and that includes really putting in place, doing a staffing assessment, figuring out what each individual practice site is going to need in terms of nursing support, in terms of medical assistance, giving them job descriptions, training them on the work, and then walking them through the process of their 3-year contract and holding them accountable with scorecards that we track at the practice level on a month-by-month basis. And those track things like how well their data platform is integrated with ours so that they can actually understand how they're doing.
Do they approach you or vice versa? How do these things come about, Tim?
Well, our clients recognize that they need help getting into this program, and our background is rural. clients, and a lot of our clients are very small, and recognized immediately that they wouldn't be able to do this without help. Larger systems ultimately have very similar issues managing their independent physician networks. It's very difficult for them to effectively work with physicians who are not part of their employed groups, and so we help them work through what have historically been adversarial relationships to put in place these types of care management processes.
So are you kind of a broker/trainer, or how would you characterize that?
We're change managers. We are we hold them accountable, we hold ourselves accountable, and then we provide expertise around compliance and quality reporting and the strategic direction of the program.
So given that's your role, I'm just curious, are you finding that there is, when you start these relationships with organizations, how kind of up to speed and expert are they in setting up an accountable care arrangement?
Well, it's all over the map. Oftentimes, you'll have a couple people in an organization, whether it's a chief medical officer or a chief of strategy who wants to go this direction, and then they have to educate their entire leadership team about it, and there will often be real wide variation in willingness to take that on and understanding of these types of programs. And so one of the things we do early on is launch meetings and on-site meetings with the full top to bottom, and then horizontally as well, anyone who's going to be involved in the program to help them understand what they're getting into.
So you're doing a lot of ramping up of awareness and kind of how-to, right, in this area?
Yeah, it's very hands-on. It's not just educational. It's here's the work that we're going to be doing. Here's the series of meetings that we're going to be managing. Here's the governance structure. Here's the work that you need to do. Here's the staff that you need to hire. So we have pretty strong opinions about this. We're working with clients serving about 1 million Medicare patients, about half of whom were attributed to ACOs across the country right now.
So this is very practical, hands-on work then.
Right. It's called sometimes practice transformation services, and CMS has funded some of this type of work through the practice transformation networks. We do a little bit of that work, but mostly we support hospitals and physicians and ACOs.
Thanks, Tim. John, what are you seeing out of OHSU and your work there?
So Oregon, in 2012, it made this transition to coordinated care organizations, and there are a couple things that are interesting about that. So first was what they took, they did a review of all the funding streams that were there in Medicaid, and so there was physical health, mental health, some transport, some cancer screening programs. There are about 27 programs. And they took all of those that were carved out and smushed them together and gave CCOs a global budget that had all of those there, and they said, take those funds and go forth and prosper. That's going to be your global budget. The global budget is going to be set so that it's going to go up at a predetermined rate. It can't go up at it had been historically going up, growth and spending going up at 5.4%. They said it had to come down to 3.4%. So that was the kind of the CCO model put forth. And then some of the other kind of bullet point types of things in there was they were supposed to work hard to integrate mental health and physical health. They had permission to spend on non-medically necessary services, health-related services or flexible services, so a lot of this addresses social determinants of health. And they were supposed to implement a lot of alternative payment models or value-based purchasing models. What we saw in that period was that spending came down. We looked at this in a variety of ways, but the most robust was a comparison to Washington State, which is similar to Oregon in a lot of ways. They didn't have a big reform happening during this period of study, and so we saw spending come in about 7% lower than Washington State. Access and quality were kind of mixed. Maybe they stayed level, maybe they went up. It sort of depends on how you cut that. There were some incentive measures where CCOs were paid to improve quality, and they definitely came up on those, but on others they went down, so sort of a mixed picture. But overall, I think sort of a sense of investment in infrastructure, improvement in getting people enrolled in primary care homes, improvement in having those primary care sites have EHRs, spending heading in the right direction, quality kind of responsive to quality measures that where you're getting paid to do well. So the state, I think, felt pretty good about its first 5 years. This year right now is a pause to review what worked and what didn't work, and there were some areas that didn't work, and then they're going to be doing contracting in the next year for what they call CCO 2.0, which is intended to write into some of the contracting, some more prescriptive things around areas that didn't work as well as they would have hoped.
John, in Oregon in particular, judging from the first 5 years, and I know you're evaluating that, is this something that's going to flourish and prosper, or is there still a lot of skepticism about it, and might it get shut down or diminished?
I think it's here to stay. So it is the way that the state has sort of shifted most of its financial risk onto the CCOs. You can think of them sort of like MCOs, so MCOs aren't going away. This is the way that they're paying for care. The metrics have generally been favorable. There's been a lot of, I think there was some political transition with the governor leaving and some turnover at the high level agencies that created some friction, but many of those issues have been solved, and I think that there's reasonable trust and communication happening throughout the state. So I think they're here to stay. There's always going to be financial challenges just with any Medicaid program, but the CCOs are here to stay as far as I can tell, at least the next 5 years, which I guess is a long time in healthcare.
Okay, so the here to stay part is good to hear, and you said you're taking a year to pause and evaluate. That's correct? Okay, thank you very much. David, from Leavitt's standpoint, what can you tell us now?
Yeah, so when I look at the healthcare system, and I talked about the business case earlier, I think that there is a fundamental challenge that we have to grapple with payment models. And that has to do with what we've historically built our system around and what we want to build it towards. So we talk about going from volume to value. I think that's a little bit simplistic. I like to think of our current kind of structure as a capacity-driven model. So under a capacity-driven model.
Capacity-driven model?
Yeah.
Start with the capacity?
No, that's where we're at. So it's where we're at, not where we want to be. So it was a capacity-driven or capacity-focused. What happens is you start with looking at services and you say, what are the well-reimbursed services? Then you build capacity around those. So think cardiology, orthopedics, oncology. You build capacity and then you try to fill that capacity. Under a fee-for-service system where you're paid for what you do, that makes perfect sense. It's business school 101. Go to where the market is and then maximize the market. Now, the alternative viewpoint is a value-based model. And a value-based model, I call it a needs-based model. You start with a population, you identify what all of their different needs are, and then you create the services and interventions to provide or fulfill those needs in the cheapest possible fashion. You make your money by doing things more efficiently. In the first place, you do it by filling it in those high reimbursed models. The challenge for many systems that are in this capacity-focused mindset is that they have invested literally billions of dollars, and as a system, trillions of dollars in the capacity. So you think of the average hospital, it costs about $2 million to build a bed, per bed as you're starting to look at these. When people go and build a new hospital, they take out a community bond. 30 years, 50 years, or in at least 2 cases, 100-year bonds. And they've basically mortgaged themselves to this mentality of, we need to drive capacity toward these systems. So when somebody comes along as a medical director and says, I think that value-based care is the future, ACOs are where we want to go, they say, look, we've got this new contract with Medicare and 10% of our revenue is coming through this risk-based model. We need to make major substantive changes of how we deliver care across the entire care spectrum. And the CFOs just laugh. They say, no. We've got this 30-year mortgage, plus we've got 90% of our revenue that's still under a fee-for-service mindset. How are we going to maintain these margins? And that's the challenge that I see organizations are in. It's not a foot in 2 canoes, it is we live in one canoe and we kind of think we want to get over to that other canoe if we can figure out a pathway to getting there.
So the CFO is trying to pay off those hospital beds, basically, right?
Exactly.
Under the fee-for-service.
They have a commitment, they've made the commitment as an organization, and they have to say, how do you make that transformation? And it's hard.
Tell us more about actually overcoming that 90-10 inertia.
Yeah. So we talk about the depth of risk, and we say providers need to have more risk, and it's going to encourage them to make major changes. If you have full risk for 10% of your patient population, that's not enough. What you need is the breadth of risk. You need to move enough revenue into these models that you can make that transformation. And if you just start with the accountable care contracts, there's not going to be enough. And so people start to think about it in a little bit different way. This is how you can start to change the numbers. So you start with your accountable care contracts. The second is you look at your own employed population. You say, well, we're fully responsible for them. So let's start building them into our calculations, and that's going to increase the amount of revenue that's going through these models. And then the third model is you look at your uninsured population, the self-pay patients that are unlikely to pay a significant portion of your bill. If you start to lump them into the same category and say, look, we're basically fully capitated, but we're getting a $0 PMPM, it actually makes sense to try to manage that population at a lower price point. So it depends on the organization, depends on how much you need to get to before the numbers start to make sense. But if you can get from 30 to 50% of your revenue under these risk-based models, you can actually really do the math and say, it makes sense for us to rethink driving capacity and actually focusing on the needs.
David, so that's a pretty compelling point, but how exactly do you get from 10% risk to as much as 30 to 50? Is it a real gradual take, or is it something you can jump to? How do you kind of make that break?
Yeah, the challenge is that in many markets, there are not enough risk-based contracts for providers.
Right.
So if you went with everything that was available, you counted your self-pay patients, you sounded your self-insured patients, you couldn't get to those numbers. And so where there is right now is at its experimentation phase. You experiment with models of delivering care under a different format, but you're not ready to make that. And that's what makes it a really rough transition, is because there's no definitive pathway where you could say we could get to that 50% that we needed for our organization. So even if you see the pathway, what you would need to get to, there's not a direction to get there. And that's the business case that we see. You know, from a policy perspective, there's a very compelling policy perspective for accountable care and value-based care. I think we've made that. Now, how do we make that business model? And I think that's the barrier that we're really going to see to full-fledged adoption.
Point well taken. So John, in Oregon, have you made that kind of leap? And if so, what brought it about?
Are you talking about the Medicaid side or the employer
When I'm talking
side?
about making the shift of at risk from something low, like 10%, to something that you can really work with.
I think that let's see, there was a movement, there was a point in time where it looked like the whole state was going that way. And so you had the Medicaid market moving in that direction, so that was about 1 million people. Low spend, so it sort of, people kind of said, okay, this is good, but it didn't get everybody's attention. Then the governor at the time said, we're going to move our public employees group in the same direction. And so everybody kind of perked up, and there was a lot of sense of the whole state was going to move in this direction. I think what happened here was a lesson of sort of the disconnect between economic models and how you think things would work and the political realities of personal relationships. So there was some scandal. The governor left. The governor was a big healthcare guy, and you could almost feel his priority was healthcare, and sort of the way he would turn his head, and then kind of the way that the heads would turn from the various agencies down to the lowest level staff. For a while, they were all focused on how do we get the whole state moving in this direction.
Sure.
He disappeared. There was sort of a vacuum there. The other governor came in. She had different priorities. There was turnover, and then all of a sudden it didn't become as important. And so I think that, and then kind of following up with sort of at the federal level, confusion around is the push for value-based care going to persist with the new administration. I think my sense was walking around and talking to different health systems that they had stopped kind of moving forward 100% to now trying to figure out which foot was going to be in which canoe and really pulling back a lot.
So this was really sensitive to particular political conditions underway then, right?
That was sort of my qualitative take on it, which went from everybody's all in, we're all going to do this, to maybe we need to go back and think about capacity building.
Wow. So Tim, having looked at this from the federal level and now going out into the sector where you are now, what do you currently perceive as this ability to shift from a less risk-oriented market to a greater risk-oriented market? Are we set up for that now?
I don't think we are right now, actually.
You don't think we are?
No. So the business case problem, as David very well described it, was something that Secretary Burwell was very worried about in her time at HHS, and that was the motivation behind what some may remember as the 30-50 goals of getting 30% of Medicare payments into value-based contracts, including a cost awareness component by 2016 and then 50% by 2018.
Right.
And it's not that the law was really set up in such a way where Congress had mandated that, but it was a commitment from HHS to attempt to create enough models from CMS and to change payment systems within the law to support a transition to risk-based models to provide a better business case. Because it's absolutely right, if if you're better off in fee-for-service, if you will be paid better in fee-for-service, earn higher margins, then why would any rational actor move? And so 2017, year of transition with Tom Price, there was just constant conversation about what's happening with value-based purchasing. They backed off of mandatory bundled payments, which sort of, in my view, closed the door on a real large-scale expansion of that model nationwide, even though there continues to be experimenting. And now, if they're going to really take the largest payment model, which has about more than $100 billion of Medicare spending under management, so to speak, or at least under awareness of the program. About a third of fee-for-service Medicare beneficiaries are in ACOs, and about 4/5 of them are in no-risk ACOs. If they really go after that, then you're going to end up in a situation where you're taking thousands of health systems and giving them a choice between being in risk-bearing models or non-risk-bearing models. Because this is a voluntary program, many of them are going to choose the non-risk-bearing track,
So this
which
is
just getting out entirely. And so I think that's going to take what momentum was there, which was tenuous, and really slow it down even further.
So, Tim, does that mean that inherently, I know we're not living in a free market, but inherently we're not big risk takers, and unless the federal government is taking a big role in this, the market is not going to lean in the direction of risk? Is that what you're saying?
Well, I absolutely believe that the federal government is the only actor in this whole system that has any chance of forcing the magnitude this size through. And it's also, it's not about whether it's mandatory or not, it's just about the set of choices put in front of providers. So if the choices are risk-bearing ACO track or a relatively comfortable status quo fee-for-service system, then they're going to choose the status quo that they know and understand because they don't see the push from the government is strong enough.
So in the absence of government push, they're going to just stay put, and there's the inertia problem again. David, back to you on this.
Yeah, so I think what's
Hey,
really...
should I be discouraged or what? I was all sold on accountable care and taking on risk and all that stuff.
Yeah, I agree with Tim that the role of the federal government is quite important because they are the largest payer in the world and they have the market heft to push things along. What I think is really interesting is looking at the change that's happened since Secretary Azar has become the new HHS Secretary. So he is a firm believer that value is the future and it's necessary. He gave some comments about a month ago or so where he laid out his future for what he meant by value. And there's a couple of things that I think are really relevant. The first is he said, he described it as the healthcare system is working really well for a lot of people, speaking to healthcare providers, vendors, insurers, and the like. He said, but it's not working well for two groups, the patients and the taxpayers. So that's his baseline, is that there needs to be major changes to lower the cost of care for taxpayers and improve the quality and outcomes for the beneficiaries.
Sounds pretty good.
Second, he said that the need is there has to be major federal involvement. And this is coming from somebody in the Trump administration. He said there will need to be an uncomfortable level of federal involvement for many actors to make them to move because the status quo is just not sustainable. The other thing that I thought was really fascinating is a shift in mindset where he really articulated what he thinks Medicare and Medicaid's role is. And this started under Secretary Burwell. She was the first one that I saw that really started to use Medicare and Medicaid under this fashion. And now Secretary Azar is going to push it forward. But typically when you think of government programs, they've been managed as a program level cost, where you have a budget and you try to manage beneath that cost. What he and Secretary Burwell recognize is that Medicare and Medicaid are not just programs to be managed, but they are major policy levers. They can be drivers of change. And he's articulated that he wants Medicare and Medicaid to lead to major changes in delivery and payment reform across the broader country. So this is not just how do you lower the cost with Medicare, but how can you use Medicare to change how the commercial payers operate and how the delivery system is being operated across the entire country. And I think that's the key. And so obviously Secretary Azar is relatively early on in his tenure, but the direction that he is taking is very different than Secretary Price. I think the gas is going to get pushed harder and that we're going to have that support that's coming from the federal government. Of course, then we need the commercial sector to follow suit, the Medicaid to follow suit. We need all of the organizations to be aligned because just the Medicare program is not sufficient. I do think it is necessary, though.
So the Medicare program, from Azar's standpoint, is not just sort of a budgetary program to manage as is, but is a lever to influence the whole healthcare sector, including the commercial side.
Correct.
And it would do that by what? Through Medicare Advantage, for example? I mean, how does it exert the leverage throughout the market?
Yeah, so I think we know that the commercial sector is very aware of what happens with Medicare.
Yes.
And so when Medicare makes changes, they often mimic payment policies and the like, and so there will some be copycat or cloning of what the commercial sector does. I think the more important way is where they're setting the expectation of what the federal government will pay for. So this is looking at the quality and the cost
Of what
outcomes.
it will pay for, or when it will pay, or how much it will pay?
Probably all of the above.
Really?
Yeah, so where they're trying to set new payment models and say, we are expecting things and we will pay less for lower outcomes. So he said on multiple occasions that he is very open and recognizes the need for mandatory demonstrations, forcing providers to get paid in a different way, and those that lose money, so be it. He's also kind of a free market type in the survival of those that succeed, and that there's a recognition that not everybody will be successful and some will go out of business. That's something that's very different from other mentalities where we need every hospital and every provider to be happy and comfortable.
Well, they do complain when they're unhappy.
They do,
Yes.
but a recognition that they can go out of business, and that's not necessarily a bad thing.
Okay. Mike Funk, you're in the private sector.
I
Says
am.
Humana right under your name, and I know you do some work on the Medicare side. How are you now thinking about this? This political transition has been extraordinary. We may not like it in all cases, or maybe we do, but this is going to affect your thinking, I would surmise.
I don't, I would say we believe our strategy is in line. I think what my personal interpretation of Azar's comments, and he's said it twice, but when I first heard it, which I think was at the Federation meeting of hospitals, what I heard him say was, we're going to leave it to the free marketplace, but if the free marketplace can't get it done, we're prepared to step in with government intervention. But I think from our perspective, I think we have to put this in context. We get into these conversations and we talk as if these transformations are going to happen tomorrow. And I've heard Governor Leavitt say many, many times, he believes we're 25 years into what ultimately is a 40-year transformation. So to get where we're all having conversation around, I think is probably 15 years out. So even should we get to where we're at and what results we're seeing with the work that we're doing in today's panel discussion, what I would preface that with is we're encouraged by what we see, but it's very early. At the end of the day, what I worry about is when we talk about, and there was conversation I think with the keynote speaker this morning who made reference to the measures. I worry that ultimately the goal here is to reach a healthier population overall that will bring down overall healthcare costs. I'm not sure that measures alone will do that, but we have to have a starting point. So I think we are where we're at today to begin the transformation, but I don't think necessarily the models and the payment structures we have in place today at the beginning of this transformation are actually going to be what we'll see at the end of this transformation.
And we want to move into that next, actually. You're sort of presaging that bit of the discussion. What do you say, though, kind of in response to David, insofar as the federal government, primarily through Medicare, affecting the whole market, including Humana? In other words, when you have your sort of strategic meetings, you're thinking, okay, Medicare is going to go in this direction, that means we better react in a certain way. Are you that much tied to their decision making?
But Medicare has always been, because to David's point, they have always been the largest payer and have carried the largest stick as a result. Regardless of what programs they've come out with, they drive the industry. There's no question about that.
Humana's always been affected by this and always.
DRGs, I could take you back, 30 years, 40 years.
That would be 40 years.
They have always driven, payment reform from that perspective, just because of the size of
Got it.
the business.
Got it. Let's talk about the new payment models. And Mike, you brought it up. These might not look like what we're envisioning today. Can you get us started on where we might actually be headed in the timeline that you described, which is, I heard you say 15 years or more. What could we be looking like?
So I'll give you my take on it, and I'd love to hear the rest of the panelists, and also if the audience has any thoughts as well. But, again, I mentioned that today it's about, a set of measures, maybe a long HEDIS, and then maybe we throw in a few clinical outcome measures, and those are our programs. And depending on the payer or the entity, there's 100 measures or there's 15 measures. And that's pretty much the way the programs are managed today. I really believe that, again, if we're going to ultimately get to the goal, which is a healthier population, I believe we've really got to start getting into disease categories. So, looking at a group of diabetics, and the goal here is really to prevent. And this is why you've got this long longitudinal run here, is because the goal is really to prevent that individual from ever having diabetes, to the extent that we can do that. But should they develop diabetes, then it's about helping that patient manage that chronic illness in a manner that leads to a higher quality of life for them, but in a very also cost-effective and efficient manner as well around resources. So that's sort of my view long term as to where we might be moving. But again, I'd love to hear the rest of the panelists
Is that like
and the
disease
audience.
management 5.0?
Perhaps.
Aha. Tim, what's your take on that? More future-oriented.
Well, I think that I personally think there are a very large number of payment models that can support a high quality healthcare delivery system. And I think that we probably know about half of them or 3/4 of them already. And that there are a lot of different types of bundle payment models that are attractive. There are a lot of different ideas around stretching out the window of accountability over time, because an intervention today pays off 5 years from now. How do you account for that? I think that on a certain level, I don't really care if the government decides that ACOs are the way of the future, or bundle payments and episodic payments that stretch over a period of time, or some combination of bundles within ACOs, or something else entirely. The real problem I see actually is the providers have to deal with all of these, and they're different from everybody, and there's just too many cross-cutting currents for them to manage a diabetic patient in Medicare differently from one who's in Medicaid or who's a dual versus one who's a commercial customer. And so until we can get to more consensus standards around common approaches to doing all of this, where you're choosing from a limited menu rather than an infinite menu, I think it's going to be hit or miss geographically, where it's going to work in some places and really just be a mess everywhere else.
So what has to be honed down? The delivery models, the payment arrangements, the outcome measures?
Well, all of it. I mean, to a first order, I think the great accomplishment of the ACO program to date is just that there are 1,500 hospitals and tens of thousands of physicians who are working on a panel set of quality measures and are tracking their total cost of care for the first time. And so those are things that they can impact. If they put in place systems, maybe they can generate shared savings, maybe not, but they're trying, and they're working together as a team. I think that that's a win. Like, over time, we need to find ways to actually wring out savings from that approach, and we need to continue to raise the bar on quality measures. Likewise, if the government decided that they, and I also was encouraged by Secretary Azar's openness to mandatory bundles, because I think it was a huge mistake to cancel that program. If the government decided to go that way and said, we're going to have 20 major DRG categories that are going to turn into 90-day DRGs within 2 years, I think that would put in place a really strong push towards quality measures that suited those DRGs, and that would, private sector would develop appropriate relationship structures there. You'd see a lot of pickup among commercial payers of that approach too.
That's real. That's powerful leverage right there. See.
Yeah, absolutely. And that, you talk to individual hospitals and health systems who participated in the joint replacement model when they were forced to in the mandatory version of that model, and they initially complained about it, and a lot of them then were forced into a room with their orthopedic surgeons and their medical supply management teams, and they had to make tough decisions, and ultimately felt that they delivered better results for the patient and saved a lot of costs for their own system, not even saving costs for the government. So I think that is a promising approach, but I don't think that you have to choose just one approach at this point in
So
time.
there's still going to be a menu of approaches then, right?
Oh, I'm sure. I mean, we're describing best case scenarios, like
True enough,
the
right.
status quo approach. There's going to continue to be thousands of different ways of doing this all across the country.
John, thousands of ways of doing this across the country?
Yeah, I think at least within the Medicaid agencies, but one sort of promising sign that I see is that, so I mentioned that Oregon in its first 5 years had some successes, some things that didn't go as far as they wanted, and one was that they really wanted the CCOs to implement value-based purchasing models, APMs, they call them, alternative payment models, underneath the global budget, and those didn't move quite as far as they had hoped, and I think a lot of that was because the directive was vague. What we're seeing Oregon now, think about now, and we see this in contracting with a variety of other states, Washington, Virginia, Pennsylvania, New York, Arizona, a few others, is that they are being prescriptive about asking for value-based payments to go into the contracts with their MCOs and MCO-like entities. And so, and it's prescriptive to the point of talking about what sort of payment models go in place. And so Suzanne in the keynote talk mentioned the Healthcare Payer Learning and Action Network, and so they've kind of have these categories of payment where one is fee for service, and two is P for P, and three is sort of a upside downside risk, kind of moving up to full population health type of management. And so what you're seeing in these contracts that's interesting is sort of things like by 2020 you're going to have at least 10% of your payments in category 2 and 20% of your payments in category 3, and so on. And so you can see kind of the, if you're actually requiring them to push a certain amount of payment into these things that are not sort of blandly, in quotes, alternative payment models, but specifically have to satisfy some criteria, that would move some of these Medicaid programs to get to pay for care differently.
Got it. Point well taken. In a moment, I'm going to ask for audience questions, points, controversial points you might have, or anything you might agree with or disagree with that you've heard thus far. So David, back to you then. Forward-looking now, I really like Michael's point about saying, hey, maybe we need to be thinking about it 15 or more years from now. Where might we land, and what would we look like?
Yeah, so as we're looking forward, I think we're going to see a variety of models. So I think that's one of the keys is there's a variety of providers out there. There's over 80 different specialties that are billing Medicare right now. And the payment model that works for a primary care provider is going to look radically different than the model that incents a respiratory therapist to provide better care. And so there's got to be a range of models that recognize the disparate amount of and types of care that's being provided.
So let me just stop you there. So
Yeah.
you just divided the world into sectors by disease state. Is that where you think we're headed? And why does a disease state really affect what the payment model ought to look like?
Yeah, I think it's a recognition that when you have patients with common problems, you actually treat them in different ways and you create systems that make sense around them. So I'll use two examples. One is a knee replacement, relatively standardized, and there's an incentive to drive efficiency within that, and a bundle makes perfect sense. So you would say, you will get paid a certain amount, you will make more money if you can do it even more efficiently. So look at your length of stay, look at your SNF utilization, look at your rehab. There's an incentive there, and a bundle drives efficiencies.
Yeah.
If you're looking at a population that is complicated, I'll use the best performing ACO program right now, which is the ESRD program. So you'd look at patients that are on dialysis, so kidney failure patients. And you say, first of all, they're a very high cost patient. They have many common comorbidities and challenges. But if you can create a payment model that's representing the total cost of care, then you have the incentive to manage all aspects of their care to lower the total cost. And so
The total cost of managing end-stage renal disease.
correct. So you start with patients that were costing over $80,000 per year on average,
Expensive.
and they saved 3.5%. That's a lot better than the other programs. That was across all of the different participants. And so I think payment models need to recognize the differences that are being provided and then be aligned with those and really try to drive what those want. So fee-for-service is not a bad thing if you're doing it efficiently and it's something that's a procedure type service. And so recognize where the payment models align. One of the challenges that I think we're going to grapple with, and this is something that Mike was getting at, is the quality and how you measure and report on that. And quality is tricky. So AHIP, a couple of years ago, put together a big committee and say, let's come up with consensus quality measures so that all the different payers can use those same different measures. Okay, Okay, so who's actually using all of the same measures? It turns out nobody is. They say, yes, we need to be measuring A1C, but I have my own preferred A1C measure to look at diabetics. So when I talk to ACOs and they have a variety of contracts, I always ask them, how many different A1C measures are you using? The record I have right now is 9. So the ACO has 9 separate determinations of an A1C measure. So which patient you see, go to a list and say, okay, this is what we're trying to beat for you. This is your benchmark. This is your score. If we could be aligned and just say, look, all of the different payers are going to use the same measures, or they're going to create similar programs, so you don't have to say, is this shared savings upside or downside only, or is this my capitated patient? But if you just kind of bring it together so there is alignment, that also drives that volume of revenue.
Got it. It's just interesting to think that the payment model could be or ought to be tailored to the particular characteristics of a disease state. And that's one way of thinking about how you develop these. Point well taken. Question, comments, yes, in the back, gentlemen? And name and affiliation, please.
Scott Marin. Hello?
Yeah.
Hello. Scott Marin with Atlantic and Optimus ACO. I think this morning I've heard at least 3 times the expression, you've seen one ACO, you've seen one ACO. As I'm involved with 2 ACOs. One is very successful, the other not so much. And we honestly cannot tell you why one was successful and the other was not. Is anybody doing any research comparing successful ACOs versus non-successful ACOs? Though even we're all very different and the areas are very different, are there some general guidelines? Is somebody exploring this topic as we move forward and look to the next step, what's working and what's not working?
David, didn't you suggest that Leavitt's trying to do that?
We are working on that. That's the Accountable Care Learning Collaborative's mission. So accountablecarelc.org, there's lots of free information there, so I'd encourage you to look at it. The challenge that you have is first recognizing the diversity of structures that are forming an ACO. So if you have a primary care physician group versus an integrated delivery system with 30 hospitals, you're going to have different approaches. And so first, recognize the organizational type. The next one is we're looking at some common processes that organizations are doing where they're trying to segment their population, because you need to go to where there's opportunity. In some populations, it's your diabetics, and in another one, it's social services. You need to get people into housing, and that's really where the opportunity is. So the segmentation can be relatively standardized. There's general learnings that we have, but one of the real challenges, and this is we were talking about in the last session, is that organizations are doing dozens of things at the same time. And which of those actually made the difference becomes hard to pull out. So an interesting learning that we found as you're looking at it, so we know that those that do more inpatient work tend to be less successful. So it's higher price, it's higher, it's a higher cost structure. What we've actually found is that those that do more outpatient is even more important than looking at the decrease in inpatient. So it's not just trying to lower how much you're doing on the inpatient side, it's trying to increase the amount of touch points that you have on that outpatient side. And that's a correlation with the net increases. But again, you have to, it's customized for each organizational type. And so, we're actively trying to figure this out, but when we find that magic solution, we will publish it, we will broadcast it, we will share it.
Mike,
I have a follow-up to that.
Yeah.
Mike and then Tim. Mike, you already said you have 1,000 arrangements. Are you learning from that 1,000 arrangements?
We are in a variety of ways, but again, I would agree with David. There's no magic sauce. There are so many variables. What we do is we work with our individual provider organizations. We share what we know. We actually put together what we call our value-based care executive forum, where twice a year we're bringing provider organizations together. Our next one's going to be in July, and I think we have some 80 or 90 people coming to that, where what Humana's role in that is facilitating the meeting and getting everybody there, but it really is about the organizations and their experiences and the shared learnings that take place as a result of that, because they've all got various issues that they're dealing with. But it gets very individualized to be able to just sit here and say, there are some basic table stakes, I would tell you. Culture is a big one in terms of having everybody on board, having an engaged medical community, around value, and then you get into IT and data and analytics and those kinds of things. I call those basic table stakes, but it really gets down to the individual. And then we all know healthcare is very different. It's very local, community to community.
But
So-
you brought up the notion of bringing people together to just kind of talk to each other and share experiences that way.
and
Tim, on this.
that's been very successful.
Has it really?
Yeah,
Okay,
people clamor to get to those forums.
got it.
So-
To come to that. Thank you. Mike, Tim?
Yeah, I was just wondering, how large are the ACOs that you're operating?
The Optimist is about 30,000 Medicare patients. Atlantic is about 60. Total, we have 400,000.
Okay, so you're then one of the biggest ACOs in the program, and so you see persistent differences in them over time?
Yes, Optimist is shared savings and quality measures since the beginning. I mean, I'll just tell you what we tell people when they ask us why one is successful. Optimist was a physician-led ACO, and we started with patient-centered medical homes, a mandate for across the board. The Atlantic started out as a hospital-based ACO with employed physicians and forced physicians. So you had one engaged population versus an unengaged population. And so the engaged population did much better. That's what we tell people. But the governance and the way we're running both programs is pretty much identical. I mean, I'm medical director of both.
Yeah.
So
Yeah, so what I was going to say, but it's not the right answer since your organization is so large. 3/4 of ACOs are less than 25,000 lives, and the noise in any given performance year, the 90% confidence interval for most of them is plus or minus 5 points against their benchmark, and so noise drives most of the difficulty in comparing ACOs in any given year.
Okay. A plethora of small ACOs. Name and affiliation question?
So Dennis Scanlon from Penn State. So, interesting discussion around the payment in, different type procedural care, acute care, chronic care, diabetes care. I guess I'm wondering, if you take something like the diabetes prevention program, is funded by NIDDK, which my understanding has been shown that you can prevent the onset of type 2 diabetes for 5-6 years, whatever the case may be. And CMS has started to pay for kind of the YMCA version of that. My understanding is there really aren't enough providers that are actually providing that. I'm curious how you see something like that fitting in with, sort of where this is all going, because this is a situation where it's not year over year. These are preventing the onset of a very expensive disease, right, where that might be preventing it from 6 or 7 years down the road, which presumably would have a lot of value. But I'm not sure that the payment arrangements or the way the contracting is done really would provide incentives. And you get the situation where if you're a provider group or you're a plan, who knows if you're going to sort of have that patient, that beneficiary kind of in your system, in your plan, down the road. So, it's interesting to think about in the context of those types of programs, which may actually lead to prevention, or what we just talked about on the last panel, same thing, investments in social determinants. Do these thoughts on whether these models can or could, account for this prevention type stuff?
John, take that one.
Yeah, so this, I think, the CCOs were set up to do exactly this, and so kind of the bullet point version was you get all the money, you're responsible for outcomes, you can spend off medical claims. There was a kind of a famous kind of example that the governor was running around the state talking about it. He said, imagine some patient with chronic disease that's exacerbated by heat and summer heat waves, and the old Medicaid system would pay for 1 million visits to the emergency department and inpatient admissions. The new CCOs can buy a $200 air conditioner and solve that. There was one air conditioner purchased. The trouble, and so this was called flexible services. It's now called health-related services. Medicare is trying to get to it. I think they're working through this, but it turned out to be some regulatory issues that I sort of characterized as a fight between the policy arm of CMS and the actuarial arm of CMS. And so a couple years ago, the new Medicaid managed care rules came out, and they said that rate setting had to follow established guidelines of actuarial soundness, and before the actuarial soundness rules were sort of fuzzy. In this case, they basically said all of your rates have to sort of have encounters or claims tied to them. And so even if we want to move to payment for outcomes and things like that, it was sort of the underlying utilization was going to drive your rate setting. And so the CCOs got completely freaked out about this, and they were worried that if they started paying for diabetes prevention, that it was going to show up in the administrative part of the MLR, and it was going to not show up in the rate setting things. And so they really backed off on this. And the push for being able to pay for things that we thought would make sense that wouldn't be medical claims really stalled. And I think that part of this CCO 2.0 thing that we're talking about now is sort of how to make that work right and still make the actuaries back at CMS comfortable with how dollars are being spent. And I think that's kind of a broad issue you heard from the last panel. And Medicaid generally wants to do those things, but how to make it work in reality still needs to be worked out.
Very well thought out. Thank you. David, on this.
So I think you raised one of the biggest silos that we have in healthcare that we don't talk about, and that's the difference between medical care and public health. So we've done a fair amount of work with the CDC and NACDD trying to get the DPP, the Diabetes Prevention Program, acted and used upon. It's validated, it saves money, it prevents disease, but there is this mental break between the public health and the medical care, which started 100 years ago, and I don't know why, but we need to start to bridge that because they are so intertwined and necessary to work together. And you teed up the other big one, that's time. We think in terms of 1 year, maybe a 3-year contract at the extreme, but you're not seeing the savings in that amount of time. So why invest in something to save somebody else money down the road?
It's the one biggest silo ever, I would think. In a sentence, Mike, we're going to go audience left, right, in a sentence. If what we really wanted to do was truly advance accountable care, and I'm talking about more risk, more taking on risk, more ability to innovate, in one sentence, what would you like to see done? Policy change, evaluation, whatever it is, what would enable us to truly advance accountable care as a concept? Knocking down a barrier, making an opportunity, what is it? One thing.
So one sentence, I would say I'm encouraged by the direction we're moving, but to the earlier conversation around social determinants of health, we too have spent a lot of innovation in that area, and what we're learning about that and the impact that those determinants have on the overall healthcare dollar is pretty amazing. So I would say more probably policy, although I think it's up to us to prove that case as an industry. But I would say more focus on social determinants of health.
Excellent. Thank you, Mike. Tim?
Certainly agree with that. My sentence would be freeze fee-for-service rates unless you're in an ACO, bundled payment, or other alternative payment model.
Aha! Wouldn't that be interesting? We would hear some pushback on that, but sure as heck like to try that.
Yeah, that's my personal.
You get a little
not
press on
speaking
that.
for my
Thank you.
client on that.
Thank you. John, what do you got?
That's a bold statement, hard to beat that one. So I think this will be maybe 2 sentences pushed into one. So really more evaluation and understanding for what works. I just hear it all the time, like the gentleman said back here, what's the difference in what's actually working, and to Tim's point, rewarding some risk taking. I think that sort of the stalling or doing what we're doing or have been doing for the last 10 years isn't helpful. I understand that it's a scary world, but I think we have to try new things and see what works.
You got it. Thank you very much, John. David?
Change our governance where we pay our healthcare leaders and reward them for doing more with less, instead of rewarding them for doing more, period.
Aha, I can hear that Federation of Hospital Executives having a little pushback on that. But anyway, each of those would in a very important way advance the ability to carry these models out. With that particular set of innovative thinking, I want to thank Mike Funk, Tim Gronniger, John McConnell, David Muhlestein. Great insights all. Thank you very much. Very, very helpful. Thank you.